There we go. That was one of them. Perfect timing. I will start by reading our ancestral land statement. We ask that you take a moment to honor and acknowledge that we are on the ancestral homelands of the Dakota and Anishinaabe. Indigenous people have a long-standing history and connection to the land since time immemorial and are the original stewards of lands and waters. Many American Indians were forcibly exiled from their lands because of aggressive and persistent settler colonization and U.S. governmental policies, but they persevered. We make this acknowledgement to honor the Dakota and Anishinaabe people, ancestors, and descendants, as well as the land itself. All right, next I would like to introduce our wonderful moderator, Dave Golden. Some of you may know Dave. If you don't, he is a pleasure to know. Please introduce yourself at the break. You wouldn't know it, but Dave started working at the University of Minnesota School of Public Health 1984, and he worked his whole career, I believe, at the University of Minnesota. He did. And so he retired recently. He's been an active member of MPHA. He was a past president, and he's been in all sorts of college health organizations and a real advocate for public health. And if it's not fun, it's not Dave Golden. And if it's not fun, it's not public health. I will turn it now over to Dave Golden. Thank you.
I don't know why I really, really appreciate being invited to come in and do the moderating thing. I absolutely dearly love MPHA as an organization, and just spending time with the people that are involved in MPHA has just been unbelievably rewarding and loads. So it's so good to see all these faces here. And when I'm so bad at this, I write something that I think I want to say to start off the day, and I get here and start talking to people, and everything just plain changes. And so I'll be brief. I promise, with just a few opening remarks. But one thing, it's so nice to see all these faces together in the same room. Is absolutely great. And the other thing that I always found in working in public health is you consistently get to work with people who work here because we want to do good for others in so many ways all together. And it's very direct. It's not to say that other folks don't in different types of professions or things like that. But here it's just so straightforward, direct service that you're meeting with people, other people, where our goal is to try and either, protect the community or do good, sort of looking out for each other collectively, which is so fantastic and can be so rewarding. And I did say all the time, if it's not fun, it's not public health, which, great. Well, because it was always fun. We always had a great time engaging stuff. We could do all kinds of stuff in this field with public health that are just fantastic and wonderful. And you get to work with people, and you see sometimes how much good your work can do. I wonder right now if how much fun it is sometimes. We're in a different sort of world in lots of ways. I don't know how they do it. But these folks that plan these forums, every year after year, come up with these relevant, engaging, timely ideas. And your timing, I don't know how you all did this, but to talk about vaccines this week, it's like, it's absolutely, I don't know how that happened. So yes, they're changing. There's stuff that we thought was written in stone, like the 10 Commandments that would live forever. And we've been banking. How many times have you used the measles example for a success in a public health effort, or smallpox or polio, or some of these, vaccination efforts that have gone on? This has been like, well, why would you ever change this in so many ways? It's like, when you give the tobacco example and all this stuff that happened related to, are we promoting smoking again? Has that happened? I was wondering if those still held on, but it is remarkable. This week, we see the report from the state where kindergartners now, with Minnesota, of all the states in the country, have dropped to the bottom third in terms of our vaccination rates for kindergartens coming in. I know 82% is all, down from 95.5% we're down for students being vaccinated, with the majority, though, not majorities, but higher rates even in the charter, meaning lower vaccination rates in charter and private schools is too going in for our kindergartners. This is also the week, or just recently in the news, the changes to the CDC website, you know, where we can't rule out vaccination and autism link. We can't say no to it, which was, it's really cleverly worded in lots of ways and even more vague and more confusing, and to understand what's, you know, well, we kind of know what the message is, but at the same time, you know, this is something we really, you know, is remarkable in our world, and it takes some adjusting. So I tried to think again, is it still fun, you know? And you know what? The other thing I found about public health people, especially recently, we had that little pandemic thing going on, they're up for engaging. This is just another field to engage in lots of ways. And besides, we have these great panelists up here. They've already got it figured out, what we need to do with vaccinations. But no, we've got a mission, and I usually find that public health folks are up for the challenge in terms of figuring out just what we do next. It's just another problem to solve, right? Like we've seen in so many ways, and so it's great that you're all here. That's very exciting because we've got another problem to solve, and we're good at figuring that stuff out. We have for many, many years. Ask Donna. Donna's here. How are you? A member of the Minnesota Public Health Association, we think for 62 years? Are you counting? You were, oh, you knew I was going to pick on you, didn't you?
Not quite 60, quite yet, but getting pretty close.
All right. And Donna also, yeah, knows everything. So good to have you here. Well, let's jump in with our esteemed panelists here today. How's that sound? And I'm going to start with Sheyanga Beecher, who started her career as a public health nurse in Baltimore, Maryland. Let's see. Oh, geez. Providing, I should read these things in advance, hang on 1 second. I'm ready. I've got to back up. Began her career as a public health nurse in Baltimore, Maryland, providing care for mothers recovering from substance use and their children. She received her Master's of Science in Nursing from Johns Hopkins School of Nursing and Master's in Public Health from Johns Hopkins Bloomberg School of Public Health. As a nurse practitioner, Ms. Beecher has lived and worked internationally. Ms. Beecher, in Haiti, Ethiopia, South Africa, and Tanzania, with a focus in maternal and child health, community health, and health system strengthening. In 2012, she began working as at Hennepin Healthcare. Currently, Ms. Beecher cares for children with acute illnesses and serves as the medical director for the Mobile Health Program, which began in May of 2020. The Mobile Health Program helps increase access to care, to pediatric primary care and postpartum care for mothers and their newborns. In recognition of her work with the Pediatric Mobile Health Program, Ms. Beecher has won the Hennepin Healthcare Pandemic Preparedness Award, the Blue Cross Blue Shield Trailblazer Award, the Commissioner's Circle of Excellence Awards, from the Minnesota Department of Human Services, the Women's Health Leadership Trust for Innovation, and the MDH/CDC Immunization Champion Award. Ms. Beecher co-leads the Hennepin Healthcare Department of Pediatrics Health Equity Work Group, sat on the Hennepin Healthcare Board Mission Effectiveness Committee, and is a member of the Hennepin County PICA Head Start Board. So thanks for that, all that fantastic work. And I know you've got it all figured out for immunization, so if you could start us off today with your opening comments, I'd appreciate it.
I want to just reiterate that I think public health is fun, and I want to say that coming here this morning after some recent news, it does feel like a warm hug, and seeing shirts like Science Saved Lives right in the front row, I'm really energized to be here. Hello, come closer. Okay, put it right in my mouth. So I started my career as a public health nurse, and a lot of what I carry with me in my current role as the medical director for the mobile unit was developed out of my time actually spent in Tanzania. there were certain times where we lived in a very rural area, probably 4 hours from the nearest hospital, a lot of dirt roads and Jeep excursions, and I would do home visits. So I would put my anti-snake boots on and walk through the bush and give a baby a hepatitis B vaccine. Or there'd be times when we would have to do government-mandated vaccines, where we would go into middle schools and line all the kids up, and they would show their arm, and we just jab the HPV vaccine. So those are the things that are formulating in the back of my brain when, in May of 2020, COVID hits, and our clinic shut down because we weren't sure what COVID was, and we didn't want to expose kids to unnecessary germs. And so my colleague and I, Dr. Martin, who has since retired, we're thinking about how do we make sure that these toddlers stay on top of their vaccines, because we were really limiting it to the less than 1 year old. So we went to Home Depot, we got our toolbox, we got a retired Econo 15-passenger white van, and we partnered with the community paramedics and created what at that time was the vaccine mobile. And I always sort of joke that this was a situation in which we were trying to convince families that it was okay to climb into the back of an unmarked white vehicle and open up our toolbox full of syringes and vaccinate your child. You know, it was very sketchy. But the truth of it all is that it actually worked. And shortly, we started May 7th. Shortly thereafter, there was a police murder of George Floyd, and everything really shifted for us in terms of what it means to provide health care, who are we providing it for, and if we're not, how come? And so that really reshifted how we thought about basic primary and preventative care. And we focused on two components of vaccines or vaccination. The first was access. The second one was confidence, and what we now consider trust. And so we really formed and developed our mobile clinic and our program based on, can we increase access to vaccines, and can we promote confidence in vaccines? So when I'm talking about confidence in vaccines is threefold. One, do you trust the vaccines themselves? Two, do you trust the vaccine schedules? And three, do you trust the people that give the vaccines? And that can be anywhere from the nurses giving the shot to the provider that's ordering it to the government that's scheduling the vaccines. And a lot has changed since May 7th up until just yesterday or today. And we're noticing that our approach needs to be nimble and adapt and still hold on to the true north that we know that vaccines work, that they're safe and they're effective. And we've done a couple of things within our program to allow the adaptation and the integrity of the work that we do. The first is that we provide care within the mobile unit. These are 2 patients in our healthcare system. We get those as referrals. We partner with Hennepin County home visiting nurses that might tell us, like, oh, this family really needs some assistance. They have barriers in transportation, barriers in finding good childcare. They have 4 or 5 kids. It makes no sense for them to pack up their car seat, hop a couple buses, and do it multiple times for all of their kids. We also get our team of vaccine nurses then look at the no-show list. And these are families that maybe aren't even on the radar of our providers. These are ones that aren't making it into clinic, don't have a home visiting nurse. And we connect with those families as well to go out to them house to house and give them their vaccines. In addition to that, we conduct pop-up clinics. And that's more familiar, I think, to folks based on our flu and COVID clinics that we've seen, especially during the pandemic. So we will partner with Minneapolis Public Schools, Columbia Heights School Districts, and Pika Head Start. And we'll set up shop in the gymnasium, in the library. Sometimes we've done it in the hallway. And it's really just helping families get access to their care in an even more easier, convenient, and trusting way. For sure, families trust their school teacher, their social worker at school, their school counselor, much more than they will me, especially if I'm wearing a stethoscope and a white coat. So it helps for us to leverage the trust built in institutions and organizations in a manner that is more welcoming to families. And we have longstanding partnerships now with these entities. And then we also will do the flu clinic, the COVID clinic, the MMR clinic, the meningitis clinic, pick an infectious disease. Once the rates go up, we will be there to help with the vaccines. And then in addition to increasing this access, these different modalities, we also help and work to promote confidence. And so we have done what we call community town halls. And I remember our first one is actually on a Zoom call with a transitional shelter in January of 2021. We had the COVID mandate, which was freaking people out. The word mandate on top of Operation Warp Speed was not the best communication strategy that we might have employed in public health. And so there was a lot of patient education, counseling, reiteration of what science is and how this looked like. And we've since taken that into a forum where we will partner with community organizations, and we will have these forums. And when I say like forums, it's not a 1 hour session. We've gone 3 hours sometimes, where it'll be me and another provider or a couple of residents or medical school students. And it's sort of like the firing range where you're sitting up there and you have 50 plus people in a mosque asking really pointed questions. And these are questions that you don't have time to answer in what's scheduled as a 20-minute visit, but ends up being like a 5-minute visit by the end of it all. And so it's a real opportunity for all of us in those venues to sit in this sort of unknown space. Like, I don't always have the answers. You are asking really good questions. It's okay. Ultimately, we're going to follow the science. And while you might not persuade anybody to get the vaccine then and there, you've at least opened the door, and then sometimes that's the best that we can do. So those are sort of the ways that over my career I've really looked at increasing access and promoting confidence in vaccines. Thanks.
Great, thank you. I love that breakdown of confidence when you're talking about the different components of who you're being confident in is wonderful. This would be great. And didn't we all get schooled by COVID? Didn't you do that? Some tabletop exercises. We did, like on campus, like for meningitis or something. What happens if we have meningitis, outbreaks for the next pandemic? Who would have thought we'd get something like COVID that usually just, this lasts a couple of weeks, not 3 years with all these other, moving parts that were going on. It was really, really remarkable. So yeah, and we're still learning in so many ways. So thank you. Let's, Elise Holmes, who's actually with CIDRAP. How many have seen the CIDRAP website? Okay, yeah, it's a great source of information, isn't it? For all kinds of reasons, so thank you, yeah. It's fantastic. Now, Elise is a program manager at the Center for Infectious Disease Research and Policy, affectionately known as CIDRAP, at the University of Minnesota. She provides organizational and technical support across multiple projects and serves as a producer and researcher for the Osterholm update. Osterholm, that's a familiar name. I don't know who that guy is. Anyway, and you can tell him I said that anyway. So anyway. This is being recorded. And Superbugs and You podcast. Ms. Holmes previously worked at the Minnesota Department as well as Hennepin County, Minnesota Department of Health, right? Was that? Yep. As well as Hennepin County, leading projects related to child and family health and well-being. With a background in global maternal and child health, food security, and emergency preparedness, Ms. Holmes has also provided consulting and program evaluation support for projects in the U.S., Latin America, and West Africa. Ms. Holmes holds a Master's of Public Policy from the University of Minnesota Humphrey School of Public Affairs and a BS in Human Nutrition from the University of Illinois. She is currently pursuing a PhD in Environmental Health Sciences focused on infectious disease risk for pregnant individuals and newborns. In addition to her role at CIDRAP, Ms. Holmes also supports the University of Minnesota's Health Emergency Response Office and Medical Reserve Corps programs. So thanks for being here.
Right. Well, thanks, and I appreciate that intro because I'm wearing a lot of hats today. I'm wearing a CIDRAP hat, I'm wearing the hero hat, I'm wearing my previous MDH hat a little bit, and then also a mom of a 3-year-old. So I'm thinking about what that kindergarten entrance rate is going to look like in a couple years. I have brief comments on about 3 things. So I want to talk a little bit about what motivates me to keep coming to work in public health right now, what keeps me up at night, and what I'm really excited about on the horizon. So what keeps me motivated right now, what gets me to work, and right now it is a lot of the work with the Vaccine Integrity Project. So that's something that was launched at CIDRAP, and I want to make it very clear, because Karen came up to me, she said, oh, you're up there in the Vaccine Integrity Project. We have such a huge team, a really important team across numerous different institutions that are coming together. And one of the biggest clarifications I want to make with that Vaccine Integrity Project is that we are not replacing the CDC. We cannot replace the CDC, and no one can replace the CDC, because the CDC is unique in the data that they have, the authority that they have, the amazing scientists that have been working there and dedicated their careers. And so I just want to make that really clear, and that what we're trying to do is provide a stopgap for trustworthy information on vaccines. And so that first project that we did with the Vaccine Integrity Project was really around the respiratory viruses for this coming season. So COVID, flu, RSV. And that was because we would normally expect the ACIP to provide information on what was the latest epi from the last year, what new vaccines do we have, how well did we see them perform, and we weren't getting that information. And so we thought, well, I guess we need to produce that. So we did a systematic review, and for anyone who's done a full systematic review, it was a lot to do over the course of 3 months. It's now published in the New England Journal of Medicine. That was just a couple of weeks ago, and provides some really great information on COVID, flu, and RSV. I think it's still worth a read, but if I had to give my bottom line, these pathogens are really dangerous. They do put people in the hospital. They do kill people. We had a record number of pediatric deaths from influenza last year. But our vaccines are really safe and effective. And I know people are tired of hearing safe and effective, but it is true. So we need to maybe have some more thesaurus words for safe and effective, but they're still true. They still ring true. Our next project is around hepatitis B birth dose, because we know that that's really been in the news lately. So our goal is to have some more materials, and so stay tuned for that in December. So that's what keeps me motivated. What is keeping me up at night? And it's a lot of things, but I would say it's me putting on my MDH role from previous years as our lead for autism for the state of Minnesota. And we've seen this rhetoric for years. This is not new, but how mainstream it's become is so incredibly frustrating and so incredibly harmful. And I think there's the harm directly from that sort of anti-vax, anti-science community that is putting people at the center of a myth and a controversy that never asked to be. And not only is it decreasing vaccination rates, and everyone here knows that it's bad that we're decreasing rates of vaccination, but it's doing so much more harm. When someone is told that their child is full of heavy metals or toxins, they will look for ways to detox that child or adult that can cause severe physical, psychological damage. And so we have to think about it outside of just vaccines, but that those vaccine myths cause other harms. But the other thing I want to bring up with this group is that we in public health, responding to that myth can also cause harm. And the more that we say, oh, don't worry, vaccines don't cause autism, we center autism as, I think in Karen's words, a tragedy. She put in the Voices for Vaccines newsletter. Autism is not a tragedy. And what we need for autistic adults, for autistic children, we got to remember there are autistic adults too. We don't only talk about children, but we need to make sure that there's inclusion, acceptance, and services. When I was at MDH, I think something we heard regularly, I had an advocate that I worked with in Brooklyn Park, and she said, we have this wonderful group of families that we're trying to do supports and services. And we just know when a measles outbreak comes up, all of a sudden public health swoops in and we get a lecture about not vaccinating kids. And we've been here trying to figure out how to get supports and services. I need a neuropsych referral. I can't get the advocacy that I need in an IEP meeting. And so if we're only showing up when it comes to vaccine preventable diseases for these families, then we're telling them something about what that myth means and how we prioritize our communities. So I just want to be, really clear about that. And then the last thing, what excites me on the horizon? So I'm also doing a PhD in environmental health and infectious disease, and I'm really excited about new vaccines that are coming. I know that we're like really nervous about the ones that we have that people aren't taking, and that like the idea of new ones is like, oh my gosh, this could never happen. But there are so many exciting ones that are coming down the pike. Some for Group B strep and neonatal sepsis. For UTIs, can you imagine if we had better UTI vaccines in long-term care? If we had ear infection vaccines, how we would reduce the number of antibiotics that we're giving to young kids. CMV vaccines, huge. And so I think that excites me. And I know there's a lot of pessimism and hesitancy that those things won't be picked up, but I do think that we can pave the way so that when those are ready, we can use them. So those are the things that I'm excited about, what motivates me, what scares me, and I look forward to chatting more about that.
All right, y'all, we got quite the panelists up here. We might have to extend till noon. How are we doing on time? This is fantastic. This is wonderful. Thank you for that intro. Next, we have Inari Mohammed. Inari Mohammed is a research project manager in the Division of Epidemiology and Community Health at the University of Minnesota School of Public Health. She works on the illuminating and addressing structural racism in the healthcare industry project. Before her work at the U of M, Inari was a health equity epidemiologist at the Minnesota Department of Health, Minnesota, for 2.5 years. Inari is passionate about health equity and centering the voices and experience of marginalized communities in public health research and practice. She's a 2-time graduate of the University of Minnesota School of Public Health, having attained her MPH in 2019 and PhD in epidemiology last year. Her doctoral research focused on assessing vaccine hesitancy and gaps in vaccine coverage among BIPOC Minnesotans. Let's welcome Inari, and congratulations on a recent PhD.
Hi, everyone. Thank you for having me on this panel today. Hello to my former MDH colleagues. So growing up, I'd always been fascinated with infectious disease. I was born in Ethiopia, and I lived there for the first 7 years of my life. That's where, my parents are from as well. And growing up, my mom would always talk about, her brother who had polio and survived, and her sister who she thinks passed away from polio. She talks about how she had malaria, and her other siblings had malaria, and all these infectious diseases that were sort of big deals in their lives and changed the trajectory of their lives. I remember when I was really little getting in this long line to go get a meningitis vaccine because there was an outbreak in our city. And so, I feel like I was sort of destined to really work in infectious disease and vaccine preventable diseases. And so in this climate where, I guess for me, I'm like, duh, of course everyone should get vaccinated. Like, I've lived in a world where that was a matter of life and death. And so here, when we're sort of in this environment where people are having doubts and having questions, it's pretty sad and it's pretty concerning. So, in the for my doctoral work, I did research around vaccine hesitancy. I used qualitative data to understand drivers of vaccine hesitancy among Black women, and used quantitative data from the Minnesota Department of Health to assess racial and ethnic disparities in the uptake of MMR and HPV. So as many of you know, there are serious racial and ethnic disparities in who's getting vaccinated, which has implications for infectious disease outbreaks among already marginalized communities. The findings from my study show that it's important to disaggregate large racial and ethnic groups because both immunization rates and drivers of vaccine hesitancy among subgroups tends to differ significantly. In public health, we often lump groups into large categories: Black, Asian, white, Hispanic. But we know, like in Minnesota, Somali Minnesotans are different from African American Minnesotans, who are different from Caribbean Minnesotans, and we miss key information when we don't disaggregate large racial and ethnic groups. So, in this era of vaccine misinformation and disinformation, my work also touched on ways we can address this issue. I found that Black Minnesotans want clear and culturally appropriate communication. One of my papers was specifically about the COVID-19 vaccine, but I think the findings apply to other vaccines as well. Communication needs to be in the right language, the right dialect, which we often miss, and in the most appropriate media for a community. Not everyone reads. Not even, you can translate something into every language, but you'll have pockets of people who are not literate, so having flyers isn't always the answer. And then beyond the messages, the messengers are important. So people are more likely to trust those who look like them and people who come from their communities. They want to relate to the messenger and feel confident in the information they're receiving. That's why having a diverse public health and healthcare workforce is important, because that's a key aspect of improving confidence in public health communication. And additionally, asking communities that have faced significant historical trauma or have been the target of misinformation campaigns to trust a vaccine without first addressing the deep concerns and injustices that drive hesitancy is a tall ask. We need to center the voices of BIPOC Minnesotans in both research and public health practice to allow for authentic insight into important issues that affect marginalized communities and marginalized communities. In my research, I was able to interview 60 Black women in the Twin Cities who came from a wide range of backgrounds. They were African American, Somali, Caribbean, West African, first generation immigrants, third generation immigrants. And going into it, I think there was this sort of, and I think it's prevalent in public health research that Black people don't participate in research or they don't want to engage with academia, but that's not true. They want their voices heard in this, they want their voices heard, and they want appropriate platform for their opinions and thoughts. And so, as we fight against vaccine misinformation, we need to really platform the voices of these marginalized groups. So that's what I have to say. Thanks.
Thank you. That's the other thing about public health, and thank you, why it's so near and dear to my heart as well, is, we really, really think about marginalized populations and how important they are to our work. And so thank you for this work you're doing. And I'm sure you all are burning with questions right now. If you're not, there's something wrong with you. No offense intended. This is great, but let's start off with a few, I think they just do this for me because I need help. They give me some questions to ask, like now already teed up. And so if I can just read, then thing will go okay. But I'll go modify the first one a little bit. So right now, when you think about efforts that are being done to increase vaccination rates to sort of, or at least, or even just stop them from dropping, sometimes we just, want to turn the corner here. What do you think are the most promising things that are happening right now that show some promise for us that we can hope for anyway? Anybody just can jump right in with that one. If you need a few more minutes, we've got. Yeah, I guess I messed up already. Or maybe efforts that aren't so promising that you have concerns about, I guess, too. I guess that's another, at least you kind of referred to a couple of things there, too. So either direction, actually, that would be good.
Yeah, I guess I'll kind of reiterate that vaccines first and vaccines only communication, I think, I think certainly harms us, whether that's in the educational space or, we are talking about from a social media lens, like, how do we create, this, vaccine information podcasts. And I said, like, a vaccine hesitant mom isn't going to just start listening to a vaccine hesitation podcast out of nowhere. Like, are you going to talk about infant feeding? Are you going to talk about safe sleep? Are you going to talk about anything else that matters to this person? And so I think that's maybe a misstep that we can think about.
I think along those lines, I sort of have both feet in the care providing world and healthcare and the public health world. And one thing I see among my peers that provide care to kids and families is that, similar to what you said about vaccines first and vaccines only, isn't as effective as it once used to be. No one's going to get the vaccine because I said so. And so what's also interesting along those lines is that pediatricians still continue to be the most trusted source for families when they're looking for information. And that trusted relationship builds over time. So you need to talk about infant feeding, infant behavior, or pediatric behavioral issues, and bring it all together. So when the time is right, and a patient says, "What do you think about this, HPV vaccine?" It's key to help over significant time and effort spent over developing that relationship. And we're hearing it also with our community partners when we do the town halls. They're very against us coming in and saying, "Give the MMR shot." It's several meetings over the course of a year. We talk about healthy pregnancies. We talk about navigating the healthcare system. What does a medical home and a PCP mean? And then we bring in, and by the way, these are the vaccines, and these are why you get them, and this is how, it works. And so I think it's targeted messaging about vaccines. We already have that from the other side. I think we need to be a little bit more holistic in how we approach engagement with our community and include vaccines as a part of it.
During the COVID vaccine rollout, I was part of a group called the Seward Vaccine Equity Project, and we worked in the Seward neighborhood to do like vaccine pop-up clinics in mosques in the area, and it was surprisingly really effective. We had a lot of people, wanting, like, who were already at the mosque, who were like, "Oh, the vaccine's here, might as well get it." And people who were like, "Oh, okay, we recognize the faces of the people giving out the vaccine, so we'll trust, what they say." So I think that sort of model would be, really helpful, bringing the vaccine to places where people are already congregated and sort of trust and feel comfortable in the environment. It worked well for COVID, so I don't know, maybe flu shot, childhood vaccines, I don't know.
Right. It's interesting. Like it used to be, a lot of ways, like you described, you just get these vaccinations, just do it. I recommend it. And then when we're getting some hesitancy, a lot of times people like me, my first reaction is, well, just show them the data. And then if they don't agree, show them more data. Because my driving, well, if you're not convinced yet, I'll show you more. Which is now causing the recipient to dig their heels in even deeper to their own, their own beliefs. And so, yeah, you all are referring a lot to the word trust. And so what sorts of things do you think we need to do, especially around vaccinations, that's going to, and I think you're already, answering this too in a more holistic way, is I don't need you to just trust me about vaccinations. I need you to trust me as a person and a professional. And so, yeah, could you talk a little bit about that, some of your efforts or what you think we need to do more of in this area? It's not enough to just go in there and say, well, you got to trust me. I would just tell them to.
Yeah, I could say. What you said about data, people who are vaccine hesitant also have their own data now. So, so I guess to talk about the problem of vaccine trust or distrust, it's a complicated problem. So I think the solution has to be multifaceted. I think we as a public health community need to understand that the trauma our predecessors inflicted on marginalized communities, which is still at the forefront of many people's minds when they engage with us. And so, going back to the qualitative research that I did, my African American participants still talked about slavery and how things that are done, even as far back as slavery and Henrietta Lacks and all these things still sort of come to people's minds when they engage with the healthcare and public health system. So acknowledging and addressing that is important. And then I think people's experiences in the healthcare system make a difference in how receptive they are to vaccine recommendations. When you have an unpleasant or discriminatory experience, or even when you see a video, like there was a video that went viral of a woman in labor in Texas who was being ignored by providers. So things like that, make people uncomfortable or with healthcare providers and their recommendations. So I think it's not just building trust only related to vaccines, it's building trust with the whole system and engaging with the patient well before, we recommend vaccines. Yeah.
I think the thing that I've seen with patients in that moment when they're deciding whether or not to get the vaccine is fear, and I don't think we give that fear enough credit. I think sometimes we dismiss patients, oh, they don't know any better, oh, they're just here to antagonize me, they're, sucked into the social media rabbit hole. And all of that stems from whether it's historical trauma, a personal experience, or their perception of risk. And I know there's like public health stuff out there about the quadrants of where you stand on the risk. I've seen families that will go through the counseling. We've had a community health advocate from the same culture, from the same village, come up with the family. They're ready to give the vaccine's drawn up, and then a parent will just say, I can't do this. And that sort of emotional response, it's significant. And I don't think, at least for me as a provider, really understand that. Especially, for example, with MMR and autism. If you're in a community and you see autism and you have seen it stigmatized and you've seen the way that it's treated among your peers and the media and social media, that's a real risk. On the flip side, I've cared for a family during, one of their mini outbreaks of measles that came in to be cared for with potentially measles, was not vaccinated, and at that point you could see the risk shift. Do I get measles or do I get autism? And that family got MMR vaccine. So it's just a matter of really understanding the psyche that comes with vaccines and what it has become. It's a new beast, and I don't think we've tapped into that yet. And then understanding how to utilize and leverage trust and risk benefit, and understand that can change sometimes from moment to moment, and having everybody available to address it from moment to moment.
Yeah. I mean, I think you guys have said more than enough, but if I had to have a final comment on that, I would say sometimes we ask people to trust us without asking ourselves, are we trustworthy? Have we followed through on things that we've said before? Have we met people where they're at? Have we thoroughly answered people's questions and spent the time with them that they need? And especially for pediatricians, I think, one of the biggest issues is that they have no time to address those things. And so what are other ways, whether it's maybe outside of a peds visit, that we can be answering those questions, that we can be building trust so that you can walk in and have that trust rather than trying to demand it?
Oh my gosh, yeah. Yeah, some of that is just profound. The visit time is remarkable, and how healthcare has become an electronic health record and number of patients per day in these 20-minute slots. And of that slot, you maybe see your provider. What do they have? 7, 8 minutes a lot of times, with you between the rooming and everything else in terms of the process, which has really changed that face of healthcare. Well, I could go on asking questions, but you all will do a much better job at asking questions. So we're going to take the next 15 minutes. Now's the time for that, right, Lindsay? Aren't we doing that? We're going to take the next 15 minutes for you all at your tables to discuss with each other some questions that you might have and to write them down on some cards that have been provided for you, even pens. And so, and with this one, have some fun with your questions for these folks.
Thank you.
Are you still part of the MRC?
What's that?
Are you still part of the MRC?
information. I know. Really great. Yes. Okay. So these are off now, right? Okay. Because the online people would hear your conversation. I mean, I'm sure nothing's secret, but we have like 15 or so online. We have a good group in the room. Okay. I'll keep getting questions to you. Fear. I like your terminology. Really good, you guys. Thank you. Help yourself to beverages or food. We will start right away though at 9 because I think there'll be a lot of good questions.
Oh my gosh. All right. Okay. Is this on?
You say 1 minute warning and I'll do one more lap.
Okay. This is your 1 minute warning. 1 minute warning. Lindsay's doing one more lap around. Yeah, I'd get it together. These questions are really weak. No, not great. Hope you can't hear me anyway. Yeah.
All right, here we go.
These are awesome.
You're up. This is the hard part, right?
Oh my gosh, this is great. All right. So let's, I know, it's so fun to start talking to your fellow colleagues. Again, like I say, the most I found the most rewarding part about being part of MPHA as well as just the public health field in general, was I did enjoy working with the people so much on a regular basis, on a day-to-day basis. I just met some of the greatest people time and time again working in this field. And I remember the first time I ever went to the American Public Health Association conference where there's, 12,000 people there, this giant, massive, and I felt like I'm 12,000 of my best friends. I mean, one after another of these folks. And so sometimes just the greatest thing about work is the people that you're working with. So again, so glad you all are here and also working on this. We're going to start off a question that a lot of your questions have alluded to in some ways, and that is, so what do you think is contributing so much to this lack of trust that we all seem to be acknowledging is going on as one of our root causes for people not getting vaccinated? So for our panelists, anyone want to go first on what's causing our trust crisis here?
The one thing that we addressed head on was the concern that families had about the expected fever, aches after a vaccine. We were introduced to that first when we had our newcomer influx from Central South American unauthorized immigrants. We were seeing them in the schools, and they, unfortunately, while they had their records maybe in Ecuador or Mexico, when they crossed the border, they had to get their vaccines all over again. This is the previous administration, so they get 10 vaccines. They might have been gone. Then they went to maybe New York, and then they got another set of vaccines, and New York doesn't talk to Minnesota. So they come to Minnesota, and the school nurse is like, they need their vaccines. So we would approach them, we need to give you 8 vaccines if you want to be in school. And the response is like, no, every time my kid gets these 8, 10 vaccines, he's sick. And we hear that with it's 8, 10 versus just 1. So we, since that point, have been telling every parent, your kid will get a fever, your kid will get achy, that is normal. It's treatable with Tylenol, ibuprofen, and in a couple of days it'll be gone. And then we created a couple of videos specific to the Black community, Somali community, American Indian community, and Latino community that specifically calls out and shows like cartoon figures shivering with the temperature, that this is normal and expected and much better than the actual infection. That has helped a lot, we've learned, especially when they get concerned about does one vaccine cause less of an effect than 10 vaccines, and trying to play out that conversation. But those side effects are a concern sometimes.
I think I'll add, when we're talking about trust and hesitancy, is there's some pretty big differences between communities, and so we certainly can't treat them like a monolith. And one, in terms of some of the work that Jillian Steele Fisher is at Harvard, she does some really interesting polling with families about why they're being vaccinated or not. And one of the things that she noticed that was specifically in folks that were in the more conservative political leaning, that were predominantly white, was that a lot of their reasoning behind not vaccinating was just being told that they had to. And that over even the fear of some sort of something was, I don't want someone, and someone that I don't trust, telling me that I need to do it. And I don't necessarily have a great answer to that other than like, yeah, I mean, I know a lot of people that don't like being told what to do. I don't always like being told what to do. So I think that's another whole separate thing that, yeah, providing more data doesn't solve that problem. And there's a really great podcast, and because I'm a podcast producer, I have to talk about podcasts. But Brenda Artakaria and her group have a podcast called Why Should I Trust You? And it's really, really interesting. And sometimes it makes me want to pull my hair out because they interview folks that are very prevalent in MPHA. They went to the Children's Health Defense Conference and interviewed folks. And I know there's a lot of tension around, did we platform people? Did we give people a microphone to talk about misinformation? So I think, I know there's a lot of folks that have different opinions on that, but it is illuminating to hear at least people's expressed reasons why they're not vaccinating. And, there's probably some underlying stuff too, but yeah, we're not a monolith. And by we, I mean every human being.
I think it's interesting that people will trust doctors to set a broken bone, or, they'll rush to the ER if their kid's like vomiting or something. But that trust sort of goes away as soon as vaccines are mentioned. So I don't know. I think a lot about, people that I know that don't vaccinate their kids, and particularly in the East African community, it's just really all about, autism, autism, autism. Even though like immunization rates are down, autism rates remain steady. So I don't know what's sort of that, I don't know how to bridge that gap. Or like, how do we bridge that gap between, like, okay, autism rates are steady even though kids are not getting vaccinated. So what do people want to see to reassure themselves that vaccines don't cause autism? And I don't know if we've gotten a clear answer from the community. What will it take for them to trust vaccines and to trust providers? So I don't know. Sorry, it's not an answer.
So you guys don't know either.
But I think it's okay to say that. And we've been saying that at our community forums. We'll discuss autism head on. We'll say that this is what we know it is. It's something in the brain. We'll talk about some of the theories behind it, and we don't shy away from it. Because in a doctor's visit, I think I'll slip over it pretty quickly just to get to the point that you need to get vaccinated.
Yeah.
And I think it warrants a lot more conversation than that.
Yeah. Yeah, it's really, really fascinating. I was thinking you're talking, or listening to you talk too, and I'm wondering how much we trust our patients or our community in terms of their ability to decide as well what's going to happen with them as well, which is just another part of that trust, like you trusting them trusting us. But right now we've been, well, anyway, I'll go to this one next. I work with primary care and pediatric clinics across the state. Staff often ask, how do I talk to patients and families about vaccine hesitancy? Can you recommend some good resources to give the clinics about this topic?
Not the CDC website.
I'm looking at someone that provides some really great resources. So come talk to Karen afterwards. But Voices for Vaccines has amazing resources. So I'm going to lift them up as number one right out of Minnesota here. I think another really great one is CHOP, the Children's Hospital of Philadelphia. They have some really great resources, especially if you have really specific questions. So if you have someone that says, like, I'm concerned about aluminum, and you can go through and you can look at aluminum, or I'm concerned about HPV. And so they're really, really detailed, especially some of those, like, for people that want that really sciencey answer, but in a really understandable way. So those are my go-to resources.
Say the MPH website. Shout out to our MPH folks.
And sometimes too, it's just we're going to keep trying. We're going to keep trying different ways and seeing what sort of hits with some groups or individuals. And how about this one? How do we deal with people who are scientists and doctors but not vaccine experts who spread misinformation to different communities? That doesn't happen, does it? Any thoughts on that one?
One thing I think we need to get better at is entering into the space that perhaps we've avoided entering into. I don't think we need to compete with others, but I think we need to at least be in the space. Because if we're to do a two-sided thing, the other side is definitely up there, whether it's podcasts or social media or conventions and door knocking. I mean, it's all there. And sometimes we rely on the data and say, well, this is just what's true, and we leave it at that, but it's not working anymore. So I would advocate for any of us to take up a platform, use your voice, and just be out there just as much as everybody else.
And I think we need to recognize sometimes when we're out of scope too. We don't love when people are speaking on a scope. I know I used to work in my previous life as a pediatric dietitian, and we always loved when, and a shout out to my dermatologists and dentists out there, but when they're out there providing like sometimes really wild nutrition advice. As much as we have people on the peripheries of different fields that probably have slightly more understanding of how to read a scientific paper, we need to know that, I'm coming in, I'm not going to give a talk on cancer screening because that is not me, even though I probably know more than maybe your average person off the street on cancer screening. So sometimes we need to know when we're in our lane and when we can reach out for friends and pull connections that I know if we're going to have a panel on something related to, pediatric dental care, that I know who I can reach out to for those questions. And so I think we also need to be comfortable with that. I don't know, here's a colleague or here's a connection that I have that can more thoroughly address that issue.
Yeah, I think, social media, like the stuff that's on social media is really intense and it's really scary. But I mean, there's like some Instagram people that I think are doing a really good job addressing these videos that like anti-vaxxers, anti-science people post, like Dr. Zachary Rubin on Instagram and Dr. Jessica Nurick. And I find their like explanations and the way they address misinformation, disinformation wonderful. And I wish we had them, but like other languages on like TikTok, because I do know, like, again, speaking from the East African community, people are on TikTok a lot and on YouTube, and people will send me stuff like, oh, did you see this TikTok? The COVID vaccine gives people HIV. And I'm like, no, it doesn't. But it's like playing whack-a-mole with like like when you like knock one down, another one pops up. So
And then our response is, here's a pamphlet.
yes,
Right?
yes,
That's what I'm talking about when
yes.
it's like we need to be in the same space. And I think, unfortunately, public health tends to be a little bit slower in our models of communication. And so could we enter into TikTok or whatever?
Oh my gosh. The next question I had teed up here is where you went, and that is, do we need public health influencers? Now I'm okay. I'm just about to be 69 right now. I'm really old. When we first started, we didn't have that internet thing even when we were first working. It just didn't exist. And sorry, I know a lot of you have had to hear that analogy time and time again. I've been convinced that this is the dark side of the universe when it comes to mental health. Do we jump in with the evil empire out there of social influencing? Do we? Sorry, I'm a little opinionated on anyway. It says it goes off while I'm up here talking. So, but what do you think about that? I mean, do we just go all in? Do we? And would people even look? Could we get material that people would look at? So, yeah.
Yes, if you're not on the table, you're on the menu. So by not being on social media, I think the public health community, we're doing ourselves a disservice. Yeah.
I'll add, that is something that CIDRAP is working on. We currently have a posting, it might be closing this week, for a digital communications manager, so we can vastly expand what we're gonna have on social media. So that's exciting to come from CIDRAP, but I will say, in addition to that, when we're having kind of these landscape discussions with different folks over the course of this past summer, on what's being posted, who has a website that's debunking stuff and who's putting things on social media. And I think there's some hesitation that people want to step on each other's toes, or like, well, we don't want to repeat what someone else is already doing. And I think there's some good reasoning on not reinventing the wheel. But more than one of us can be saying this. And I think it helps if there's more than one of us out there saying it. So I don't think we need to be as concerned with duplicating right now. We need it as many people as possible doing it well.
One final thought to that, and I agree with you. My 13-year-old would say he's the only 13-year-old without a smartphone. But
13 and no smartphone?
no. You're welcome to come to my house when we have that conversation. I'll just need some support. But the truth of it is that when we think about those that are having children and of childbearing age, we're creeping up on Gen Z, and their mode of communication is the smartphone. And so if we're not on that space, and I don't think that we need to be as proliferative as maybe influencers are in that space, but at least, come on, just a couple, right, in there, that would be helpful.
Let me talk about the HPV vaccine while I do my makeup, like, you know?
Oh, man. You know, this is great. I just remember being so wrong about so many things. I remember when the internet came to life, when it started to be a thing, I thought, what could possibly be better? Access to all this information all at once. And then we just went and wrecked it by deciding we can just lie real good on the internet or create whole worlds of fiction, which is also absolutely incredible. And don't you all go out and self-diagnose before you go to the doctor based on your symptoms? And ChatGPT is even worse. The AI is like, I just plug in my symptoms, hear what you got. I'm all set to go.
always
I'd hate to be a
cancer.
provider right now. It is an amazing, amazing world, yeah, and it's just going so fast too. So yeah, 13, no cell phone or no smartphone. Okay, good for you. I don't know. Yeah. How could expanding scope of practice for roles like community health workers potentially increase access to vaccines? Any thought on that? Oh, geez.
This question, so I'm going to probably share a non-mainstream idea. Over the past 5 years, I had a chance to sort of see firsthand what healthcare could look like. And if you think about the construct of medicine and healthcare system, and we know that it's rooted in sexism, racism, all the isms. What if we sort of flipped it and reevaluated it from the perspective of the patient? What would that look like? And I think there is a lot of room, and we've sort of done this with the pharmacists, for conversations and administration to be handed to individuals that are in the community, like community health workers. And I would love to see that because, one, they have time to do it, right? We're not making a financial model out of community health workers like we are out of pediatricians. There's not revenue and RVUs to track. It's really emphasizing the dialogue and the connection between individuals. Two, they're in the community, right? They're not confined by a wall, and there's some level of power differential that happens when a patient walks into the exam room and the doctor's there with a white coat. And I think, if anything, that COVID taught us is that our current structures of healthcare may be obsolete, and how can we reevaluate things? And I think the pushback that we're getting from patients is that agency that they developed, and good for us for developing that agency to say, I am in charge of my healthcare, I have some questions, can we discuss this? And I think shifting who, like I said in the beginning, trust in who provides the vaccine schedules, and the government agencies that supply them. That includes with understanding, is there a way to better serve our patients and community as it relates to their health care?
Yeah. Any
She's
other
the
off
expert.
the wall?
Yeah, I was going to say more community health workers, more family home visitors. That's always going to make me happy.
All right, well, let's get that done. Seems to be consensus for expanding that scope of practice. Let's see. I work with community organizations serving older adults. We have required staff and volunteers to be vaccinated for COVID and flu. We're struggling to know what to do now. Can we still require staff, volunteers to be vaccinated? What do you think about, the different arenas where we're mandating vaccines as well? Is that helping us, hurting us? How is that going?
I can speak to my experience with my current healthcare system is that we do require influenza vaccines. There's also an option to decline. But then it's really from the perspective of, economic hits if you take time off of work, but then also infection prevention. So I think if there's an option to frame it as patient safety, which you're committed to in your employment, there's more of a backing as to why you can enforce it. But I think also we can't enforce it anymore like we used to. So there has to be other measures in place, like wearing a mask, making sure that you're doing X, Y, and Z to minimize your risk of getting it and spreading it. On that note, I'm a little perturbed and, frustrated by the rise in personal exemptions that we see going up. And I wonder if there's any thoughts to how we address that or what others have done in their spheres.
Mm-hmm. I mean, policy is our favorite weapon in the land of public health. We love ourselves a good policy as far as strategies. We really do. Sometimes I think it may have gotten us into trouble sometimes. Do you feel like we ever have crossed that line with our use of policy? I mean, policy mandates for a vaccine have really come from all the right places in so many ways. It's been for protection of the individual, but it's also been for protection of the herd as well. Yeah. Not just the stopping of the spread, but we are protecting others, especially that are more vulnerable, by vaccinating en masse. And like I say, policies have served us so well in so many ways. But right now, it's become much more problematic, in other words, especially to have that trust. And when we were working with COVID or anything, who were we taking our guidance from as public health professionals? Where was that guidance coming from? The CDC. In so many ways. I mean, that was our source, and especially as we moved through COVID, we were looking for those updates on a regular basis. And what's ACIP going to say next? Good old ACIP. Remember them? Yeah. And so I don't know about you all, but how many of you have lost a lot of trust in our mecca of great trust, which was the CDC? I didn't mean to say is the CDC, but how many have wavered now in your trust with the CDC and what we're seeing now is a problem for all of us, is getting that trust in what we can rely on, et cetera. But we were using that as our standard all the time, but now we're feeling the need to even deviate from those recommendations or go a different direction. So that's a struggle.
Also, access to NIH website, they remove all kinds of things that you can get there, so we cannot go there anymore.
Isn't that shocking? I mean, she said the removal of information from the NIH sites that weren't consistent with administrative values, essentially, is really, really frightening. The actual suppression of information is also quite frightening when we talk about some of the things that keep us up at night as far as, problems to address. And so, yeah, go ahead. You had a comment. I'm
curious more.
Sorry.
I was waiting all morning for my opportunity.
So talking about mandates, we talked earlier about how sometimes mandates have an unexpected consequence of making people more hesitant for vaccines. One of the Minnesota Medical Association's goals this year for advocacy is to get rid of some of those exemptions that we have for vaccines. And so I guess, where do you guys think that conversation needs to go further in terms of, like, are exemptions good or bad, or like what is mandates going to kind of have an effect on?
I can start on that one. I think it's super important, and I've chatted with, is it Juliana, I think, about that. I think it's super important. I think leading with the mandate is where we're going to get stuck. I think it kind of needs to be our net to have those personal exemptions not be available, that if we get through all of our exhausted options that people aren't being vaccinated, that final net of a mandate, or at least making it slightly more difficult to not be vaccinated. If we can keep that as a safety net. I do think it's extremely important, and I think there are data that show that it matters for people across that spectrum of hesitancy. You have the like, I am never going to get a vaccine, I'll do everything that I need to do to not get a vaccine, to people that will just like, the minute a vaccine comes out, they're gonna get it. And so I think you can capture this kind of subgroup of people that are like, I don't know, okay, my kid needs to go to kindergarten, we'll get it. And so I think there's at least a subgroup of people that are swayed by that, and it's important. One of my colleagues that I'll shout out, Dr. Sydney Redepenning, just finished her PhD on that topic specifically, and what do mandates, personal exemptions across different states, how has that impacted both the rates at 13 and at kindergarten entry? What has that done for different types of vaccines? And so I'm happy to connect any or all of you with her because she's wonderful.
So we need to wrap up, just due to time. I'm sorry. This is just a round of applause for this panel. You guys are fantastic. Absolutely. Thank you for the insightful work that you shared with us today and the insightful work that you're doing. So thank you very much. It's really, really important. And also to you all, public health people, we still are the answer to so many of these things when it comes to health for populations. You are the answer. You've done it before throughout years of history. Some big, looked insurmountable challenges that have happened along the way. I believe that you all are the answer in this world of public health to so many things that go on out there. So thank you for the work that you're doing. So please give yourselves a round of applause for that. And yeah. And I want to thank the people that had the insight to get this one up for the kickoff and during this time for a session. So thanks to the organizing committee as well. And I just urge you to please still, when you're doing it, still have fun wherever you can. So thank you very much.
All right, and let's have a round of applause for Dave, our fantastic moderator. Thank you. I have a couple more thank yous. Thank you again to the Policy Forum for planning this series. I hope that you join us for our next two, which are in the agendas, but February 13th, prevention therapies, healthcare treatment, and drug approvals, and then April 24th on nutrition and wellness. I wanted to say thank you to the Friends of the Forum, which helps support our forums here. Thank you again to Wilder for co-hosting with us. And if you are not a member of MPHA, please consider joining. I have to put a membership plug in. And then one more thing, we have our annual conference coming up next year. It'll be in St. Cloud, April 13th and 14th at St. Cloud State University. And we have our call for proposals open right now through December 30th at noon. So please take a look at that. It's all on mpha.net. One more round of applause for our panelists, and thank you so much. And thank you, Leica, yes, for doing our communications. Fantastic job. Thank you, everyone. We'll see you next time.